So tech is going to require a level of expertise in information technology that was not often required of behavioral health organizations in the past. So this section is going to address the considerations for that technological capacity based on the type of technology to be adopted. So HIPAA dictates the privacy and security safeguards that are required for the protection of our protected health information, or our PHI. The security aspects of these rules, which address how the health data are accessed, transmitted, and stored, it has to be considered when implementing our TAC. HIPAA also addresses who is authorized to access that data and how those access restrictions are going to be implemented. So organizations must establish a password management system that controls access to client data on devices that are owned and controlled by the organization, as well as any remote devices or devices that are accessed from remote locations. Also, organizations are advised to have policies that are addressing lost and stolen passwords, automatic session logouts for unattended workstations, and also having virus protection on all the computer equipment and other devices that store that PHI. Staff training effectively addresses many of these security risks. So dissemination of these policies is going to be critical for your organization. Training should include information about risks that are associated with password sharing, saving logins and passwords in unsecured locations, and forgetting to log off. And HIPAA requires policies that prohibit the transmission of PHI via unsecured email, and it provides for email encryption. In addition, policies about remote access to PHI via networks and web-based email are definitely going to be necessary. Data storage security, as defined by HIPAA, this is going to include encryption of stored data and backups, and policies about the storage of the PHI on the devices that are outside the physical control of the organization, like on laptops or universal serial bus drives, which are flash drives, and personal digital assistance devices. These policies must address the handling of security violations, equipment repair, disposal of those technologies that we no longer use. And then procedures must be put in place to train those staff members on the policy initially, and then having refreshing trainings going on an ongoing basis. And these are just a few of the privacy and security issues to consider. The Office of National Coordinator for Health Information Technology provides more comprehensive guidance and resources on compliance with HIPAA when implementing that health information technology solution. One of the things that I do want to mention here is that we can't use our personal emails to transmit that data. And we talk about business agreements. Your Google, let's say you have a Google address of firstname.lastname@gmail.com. That is not HIPAA compliant. You can't send personal health information out on that. It can't be at Gmail, at Bell South, at Yahoo, anything. It has to be something that has a business agreement, and we'll talk about that in a moment. So these business associates agreements, they're required between HIPAA-covered healthcare providers and those performing business functions on behalf of the providers, like providing technology solutions. So the Office for Civil Rights Resources, which enforces HIPAA, offers resources related to these agreements on their website, which I've listed here on the slide for you. One of the main things you need to make sure of is that you've read over the business agreement and signed it for your company, and you have a copy of that on hand just in case something happens. Because if you don't have the business agreement, the business associate agreement, your company is not HIPAA compliant in using these programs to store or transmit data. So if you have a website that is www.yourbusiness.com, you want to make sure that whatever program on the back end that you're using for your email, you have that business associate agreement so that you can start transmitting information and making sure that those emails are encrypted. But this business associate agreement is really critical. Google does have a business associate agreement if you have a website and you're using the Google Suite, and you're paying the monthly fee and everything. You can get the business associate agreement through Google, um, if that's the operating system that you're using. If you're using something else, just make sure that there's a business associate agreement. Here I've just provided some additional data security resources: the HHS HIPAA security guidance, guide to storage encryption technologies for end user devices, some recommendations of the National Institute of Standards and Technology, the National Institute of Standards and Technology guidelines on electronic mail security. These are going to be some really good places to start in setting up your TAC. So the video conferencing systems telehealth and telemental health programs typically use, they take that hub and spoke approach to delivery. And that means that clients travel to the local health or behavioral health center to access services that aren't available in their community. So this model has the advantage of averting some of those technological privacy and security complications that are associated with the clients assessing services in their homes. The implementation planning process should inform assessment of the technological infrastructure that's necessary to deliver that TAC. If video conferencing is going to be central to the intervention, issues of bandwidth, image resolution, display size, and audio quality on both sides of the exchange are going to be central to its effectiveness. Issues of bandwidth are particularly important for video conferencing. And if you're using public internet for video conferencing, it's important to consider fluctuations in internet use and the impact of that use on speed. So, for instance, high internet use times on the public network is probably going to limit that available bandwidth, and it's going to slow the transmission to an unacceptable level. We had this issue in our office, especially during COVID times, where there were so many people in the area using the internet that we had very low connectivity and we were unable to even perform evaluations over video conferencing. And then internet connectivity and bandwidth, it has to be sufficient on both ends of the transmission. Bandwidth and encryption are as important for the client participating from home as for the primary transmission site. And in addition, data security and storage are essential to consider, and they're related to unique risks when transmitting client images using video conferencing. Various video phone and video conferencing technologies are available, and they offer a range of solutions to these challenges. Audio web conferencing can be used to conduct group discussions over the internet. A number of vendors sell access to these products that are useful for web conferencing. Audio technologies are typically more familiar to providers and they generally pose few challenges. However, mobile phone use for web conferencing raises some privacy and security concerns. And for providers, the ease of use of the technology is going to be important. Some approaches using video and web conferencing are going to require technology experts to operate and troubleshoot the equipment, but it still demands at least some technical skill from the clinicians. Other models rely on clinicians to perform their own troubleshooting, and that's going to require more advanced technical skills. The physical location of the counselors and the clients while they participate in audio and video conferencing has implementations for privacy also. So the American Telemedicine Association addresses physical location requirements. And this is going to include your visual and audio privacy, the room lighting, the backdrops, any ergonomic considerations. So, organizations should consider adopting policies that require individuals to introduce themselves upon entering the room during a session, and that encouraging discussing the privacy of the client's locations with the clients at the beginning of each session. That's going to be important. Planning teams, they need to grapple with these issues in advance of TAC delivery and have plans for monitoring and adjusting their approach to troubleshooting technology issues as the implementation proceeds. So here's some resources on video and web conferencing. American Telemedicine Association, their standards and guides for telemedicine, the National Center for Telehealth and Technology T2 telehealth programs, Health Resources and Services Administration, or the HRSA, on their telehealth. Then we have telehealth resource centers and the Addiction Technology Transfer Center Network, if you want to check out any of these websites. So video conferencing has increased the awareness of issues and resources that are related to depression during the National Depression Screening Day, which is an annual event that was run by Screening for Mental Health, Inc. Since 1991. So in one example, a lecture was broadcast to regional video conferencing sites through a coordinated effort among hospitals and regional mental health centers. And then after the lecture, the local staff administered a screening tool to the community members. And if screening indicated possible depression, local staff connected that person with a professional for evaluation and counseling. Delivering treatment services through the telephone is likely to be the most accessible and the most inexpensive means for providing TAC in our organizations that lack existing technology infrastructure. Teleconferencing or connecting multiple users into an audio discussion, this can facilitate group discussions for treatment or supervision purposes. Various teleconferencing vendors with a range of contract terms are available. Although use of the telephone can be highly accessible, organizations should be aware that without any additional protections, mobile phone transmissions are not secure. So voice communication over mobile phones must be encrypted to minimize the risk of that third-party interception. And when mobile devices transmit data, they should be treated like other remote devices like laptops in terms of security. You want to have password protection, the bio things with your fingerprint or your face scanning recognition at the very least on your device. And this telephone-based continuing care has been demonstrated to hold promise as a strategy to maintain more frequent contact with clients without the barriers that are associated with travel to those treatment sites. So in one study, the clients that were completing an intensive outpatient program for substance use disorder, they were randomly assigned to in-person counseling twice weekly or to another group weekly telephone monitoring with a monthly support group. The outcomes of the clients participating in telephone continuing care were just as positive as the outcomes of the clients who had in-person counseling. So based on those findings, Aspen Point Telecare, and you can see the website there, they have implemented a telephone-based recovery support program for adults that complete treatment for that substance use disorder. So this is for up to 2 years following the enrollment in the outpatient treatment. The recovery case managers conduct brief telephone calls to help the clients manage relapse risk. And it also helps to bolster that mutual help activity. So these calls occur weekly early in recovery, but as clients are maintaining their recovery and building support, the frequency starts to reduce to monthly phone calls. So when protocols are specific and based in scientific evidence for the population, email can be effective. It can be accessible and it can be an inexpensive way to conduct outreach with these high-risk individuals and also to sustain contact with clients between these scheduled in-person sessions. There's a small body of evidence suggesting that the use of email to deliver primary clinical content can be effective because email is not a secure form of communication unless it's encrypted. Organizations and providers, they have to implement safeguards to ensure the privacy of their communication. These precautions are going to include having policies to prevent unintentional disclosure to someone other than the client, like typing in the wrong email address. Um, Confirming an email address, fully exploring the risks related to someone other than the client having access to their email account. And all email exchanges of treatment related information have to use email encryption to meet the HIPAA security rule requirements. Various single user and organizational solutions for email encryptions are available, and they're generally quite affordable. The National Institute of Standards on Technology Guidelines on Electronic Mail Security is going to provide that detailed information on the email security and the encryption. And I've provided that guide there on that link. Another option for email is the use of secure web-based messaging systems. Several large online behavioral health service providers do exist, and they often include proprietary systems for communicating with clients that might allow for sending of encrypted email and also the storage of that text communication with the client. And because emails may be subpoenaed, you should develop policies for your behavioral health program on the storage of that communication. Research Research is suggesting that before implementing email or instant messaging interventions, or any technological intervention at that, the behavioral health service provider and the program administrators should really consider the needs and the characteristics of the clients who are likely to benefit from the intervention. Consider implementing structured clinical protocols and procedures that cover the full range of the ethical and legal issues that we discussed in this training, and heed current research as you consider incorporating email into your program's delivery of your behavioral health services. A program of structured therapeutic email sent daily in conjunction with electronic support groups, abstinence monitoring, and optional individual counseling sessions has been used as an adjunct to treatment for women who are pregnant and use drugs. These clients reported the ability to build strong relationships using the technology-based program, and they found it easier and more convenient than in-person sessions. So now let's talk about text messaging. This can effectively provide brief interventions or resources to clients who are on their mobile phones. These text messaging based interventions may include reminders for medications and appointments, or regularly scheduled educational or preventive text messages. In some cases, these reminders may be managed through the EHR. Text messages are really easy to send if the client has a mobile phone and a text messaging plan. But we need to be careful because clients can be charged per character or per message for text messaging. So it's important to seek out their consent to communicate by text message and also to ensure that the clients understand the security and the privacy limitations of data transmission and storage via their mobile phone. Unencrypted text messages should never include PHI. Although there are some secure text messaging services, standard text messages may not be secure. They may be stored on the subscriber identity module card, which identifies the user to the cell phone network, and they can be easily visible to others. Encryption software downloads messages to computers and secures the mobile phone, or if the device is lost, it eliminates some but not all of the privacy and security risks that are inherent to that mode of communication. So counselors should carefully evaluate this type of information that they need to send to or receive from our clients using text messaging. If the information's inadvertent release could have serious consequences, text messaging is generally inadvisable. So consider establishing a means for counselors delivering TAC to verify their client's identity before sending and receiving text messages. Clients may also wish to consider using a screen lock or a timeout feature to keep information from remaining viewable on their mobile devices to any unauthorized viewers. Asking a client to confirm receipt of a text message and establishing measures such as auditing and remote wiping can protect sensitive information to a certain degree, but providers should generally avoid using text messaging for communication when privacy and security are of a significant concern. So, for women who are pregnant or in their first postpartum year, the Text for Baby program provides 3 weekly text messages on a variety of material and child health topics. These are going to include nutrition, prenatal care, immunization, mental health, smoking cessation, family violence, and exercise. The messages are short and they provide specific actions that women can take to care for themselves and their babies based on their due dates. And this was between February 2010 and July 2011, the program enrolled 155,000 women. So, real-time instant messaging, it can serve as an alternative to asynchronous email or text messaging exchanges. Providers and clients, they can download chat programs, which are often free, quickly and easily from vendors, and these programs require only a computer with an internet connection. However, the issues of data security and storage do exist when using instant messaging. Real-time chats and instant messaging features are widespread and they can broaden access to social support. But the privacy and confidentiality risks inherent to this mode of communication, they're expensive. Your agency's TAC policy should remind the clients that messages sent through chat programs and the chat or messaging features on social network sites like Twitter and Facebook and LinkedIn, they're not secure, and that posts to such sites are not confidential. TAC policies should also discourage providers from interacting with their clients via social networking sites and urge them to remind their clients that communications posted on such sites are public. Avoid the use of social network sites. This can become particularly challenging, though, when disgruntled clients post ratings or comments about the experience with your behavioral health program or your agency's personnel. You and your TAC implementation team should really carefully consider establishing some policies to guide agency responses to these consumer ratings and the comments that are posted on the agency's own website, as well as any other public forums. Let's talk about self-directed therapeutic tools. Self-directed therapeutic websites and applications these are typically hosted by third-party vendors. So organizations are typically going to purchase a usage license for a group of clients. The clients then receive a unique user ID and a password. The content of the self-directed therapeutic tool is developed by the vendor, and it often restricts the client's ability to enter their personal information. Many self-directed therapeutic tools target prevention and treatment of mental and substance use disorders. So, for example, college campuses often purchase licenses so that their students can access substance use or mental health risk factor reduction programs that are delivered over the internet. Another example is a secure website that provides self-directed education and secure messaging with a care manager for clients who are enrolled in outpatient mental health services. In addition, many mobile applications have been developed that lead the user through a process of screening and education and support. Applications are going to vary in terms of data security and the amount of the personal information that is entered. Self-directed behavioral health applications are frequently including web-based messaging systems that send emails to the clients that prompt them to log into a password-protected website. Before incorporating these digital self-directed therapeutic tools into your agency's behavioral health program or recommending their use to your clients, your tech implementation team should investigate how these applications address password protection, automatic logouts, firewalls, audit trails, encryption, and also an authentication. They should know what data the tool collects, how it stores and protects those data, and the extent to which it is going to share the data, including any third party access to that data. Online therapy service providers may serve as an alternative for that secure communication with our clients. These services help manage privacy and security concerns by providing encrypted chat stream identifiers and storing text communications with clients. But you have to carefully examine the reputation of these services before choosing one. And self-directed therapeutic tools, these can be attractive to clients and providers because they require really little investment in infrastructure other than access to the internet. They're going to allow clients to work at their own pace, and they're really accessible, assuming that they have an internet connection, whenever and wherever the user wishes to access it. And although some of these tools are going to allow for the clients to share information with their behavioral health service provider, they generally operate outside of the formal treatment process. So My Student Body, or if you look on their website, mystudentbody.com, Alcohol EDU, and Alcohol eCheckup to Go, these are online self-directed therapeutic programs that are designed to reduce health risks among college students and others. They include alcohol and drug courses and general wellness resources in the areas of sexual health, nutrition, stress, tobacco use. So, for example, My Student Body allows participants to develop an individual profile that's going to direct them to topic areas based on their risk, and it's going to provide links to local emergency resources. This particular program, along with similar campus education and risk reduction approaches, holds promise in reducing that risky behavior on college campuses. Organizational websites, these can provide information about behavioral health service systems in a way that can motivate people to seek out services. Some more active approaches that include discussion groups, built-in chat or email features, and other opportunities for digital interaction with staff members are more likely to engage people into service delivery. With that being said, organizational liability increases as the organization's websites become more active. Although the design and the maintenance of professional websites are beyond the scope of this lesson, administrators and TAC implementation teams, you guys are urged to consider the risks and the opportunities that are associated with embedding email and discussion group features into websites. The more active approach to website design, it poses challenges and it raises concerns that are similar to those for standalone approaches to the email and the discussion groups. Now we're going to talk about some budgeting considerations. When estimating technology costs and related personnel costs to your agency in adopting a TAC approach to behavioral health service delivery, you need to consider a full range of issues, including the hardware you're going to use, the software, the technological support, the training, and the staff support that's going to be required to deliver your TAC. Try to project the cost for infrastructure development, which is your startup, along with any ongoing TAC delivery. Unfortunately, investment in the initial infrastructure to facilitate TAC can be costly. So it's critical that you have a clear understanding of the costs and a plan to finance that development of the infrastructure that's necessary for your agency to deliver TAC successfully. So these costs that are associated with various technology-mediated interventions are going to vary widely. In addition to identifying the specific expenses that are related to the type of intervention selected, agencies have the option of leasing or contracting or buying the equipment and the services. Your organization's strategic goals, their existing technology infrastructure, and their cost considerations are going to dictate which options that you're going to select for your organization. So, in planning to implement TAC, you're going to benefit from that careful investigation of a couple of cost categories. This is going to include infrastructure development. And in that infrastructure development, the cost considerations are going to include equipment. This is including computers and servers, mobile devices for both the staff and the client to use, video conferencing equipment and telephones, cabling and other communication lines, building reconfiguration, equipment, and also cooling systems, internet service provider fees, software. This is going to include encryption systems, virus protections, applications, storage, and the security systems, expert consultation and technology, content development, your clinical materials, your protocols, your procedures, your initial staff training. This is going to include staff time, expert trainer time, and the content development, legal and accounting consultations. For example, sufficient and explicit insurance coverage. Also, development and or revision of forms like informed consent and privacy disclosures. Some ongoing cost considerations are going to include equipment maintenance, insurance and replacement costs, ongoing internet service provider fees, annual licensing or hosting fees, software renewal licensing fees, expert consultation or troubleshooting services, ongoing staff training for new staff recruits, and refresher trainings for the existing staff members, content refinement and updating of client materials, legal and accounting consultations, inclusion of extra client data and client privacy or consent management information. Medicare and Medicaid reimbursement guidelines for telemedicine have been developed and they're available through the Centers of Medicare and Medicaid Services, which is called CMS. Currently, Medicare authorizes reimbursement for telehealth services that are delivered by designated professionals in underserved areas or as demonstration projects. Some state plans dictate Medicaid reimbursement for telehealth. Some private payers also reimburse for video conferencing, and others are piloting video, text, and telephone interventions. And although these and other reimbursement structures for TAC under other private and public health insurance plans are emerging, depending on the state licensing and reimbursement policies, providers may have the ability to recapture the costs in other ways. So, for example, the use of technology mediated interventions may be incorporated as a value added service that assists the providers in meeting other contractual obligations, like improving care coordination or reducing rehospitalization. These costs may thus be recovered in other service areas. So Gilman and Stensland in 2013 of the Medicare Payment Advisory Commission, they analyzed 100% of telehealth Medicare claims for 2009, and they reported roughly 38,000 telehealth visits in 2009. Of those providers who delivered 10 or more Medicare covered telehealth services, 44% of them were psychiatrists, 3% were clinical psychologists, and 2% were licensed social workers. Although the non-psychiatric providers could be underestimated, as services are sometimes billed under the name of the physician. So the authors noted that there were only 26,000 Medicare telehealth visits in 2006, but they considered the increase to 38,000 in 2009 to be modest, with only 185 mental health professionals providing 10 or more of the telemental health visits. Although Medicare recognizes the potential of TAC and has made changes by increasing reimbursement and decreasing regulatory burden between 2006 and 2009, the barriers to implementation described throughout this training may continue to restrain reimbursement of telemental health services provided to clients who are covered by Medicare and Medicaid. Selecting a vendor to facilitate TAC is a critically important endeavor. Security, privacy, confidentiality, and regulatory requirements have to be addressed in addition to cost, usability, and sustainability of the technology. A first step in soliciting bids from vendors is to develop a detailed scope of work and a request for proposals. Many organizations choose to hire a consultant who is not invested in a particular technology solution to assist in the development of the request for proposals and selection of those vendors. This approach can bring a level of attention and expertise to vendor selection that may be attractive, especially to organizations that don't have internal technology expertise. It's going to be important to involve a broad range of stakeholders, including the clinical team and the potential clients, in the vendor selection process to assess the ease of use of the technology and any technological support the vendor is going to provide. The vendor selection process should also include demonstrations that allow potential users to operate the technology in situations that mirror anticipated live conditions as closely as possible. There's a lot of guidance that's available in selecting technology vendors and experts. Factors to consider may vary based on the setting, the approach, and the degree of the internal organizational expertise that's available. Your agency is going to benefit from this careful analysis of the strengths and the weaknesses of the vendors prior to entering into any binding agreements or sharing confidential client information with them. So, when reviewing vendors and consultant credentials, you need to consider any demonstrated experience in implementation of similar applications or services, like whether the vendor has developed or implemented similar applications in other behavioral health settings. We need to consider the stability of the vendor's company or agency, the availability of training and support, references from other customers, anticipated software upgrades, and the process for these upgrades, reporting ease and capacity, also security, privacy, and confidentiality protections, and the company and technology sustainability. Some resources that you can use for vendor selection: Telehealth Technology Assessment Center, the Telemental Health Guide, or the Agency for Healthcare Research and Quality Health Information Technology Tools and Resources. I've provided you with their websites on this slide. Data management challenges associated with TAC cannot be overlooked. So this section of the training is going to offer you some guidance on some common risk management challenges that are associated with data retention, with EHRs, and also with client access to devices that are owned by the organization. Because some of the examples of the technology-assisted services that we talk about here originated outside of the U.S., and given that the regulatory environment surrounding the delivery of these services in the U.S. is rapidly changing, administrators should really remain diligent in monitoring the regulatory and legal environment within their state. You should seek legal advice specific to your state laws and regulations that are applicable to your behavioral health program, your risk and liability, and also your insurance coverage when determining how to address the risk management issues that are associated with TAC. The issues of data management, quality, and security as directed under HIPAA, we discussed that earlier in this training. As for how much of the content in digital or audio exchanges between clinicians and clients should be stored, you need to consider whether to retain every email communication or all the transcripts of every chat. And if so, whether to contain this information within each client record. Although storing more information about clinical interactions may improve the continuity of care, it's also going to create storage space challenges, and the information may be subject to subpoena. The sheer volume of the information that text-based communications generates, as well as the added challenges associated with video storage, this suggests the need for clear administrative policies about retaining and storing that information. And then in addition to the data management and security, we have issues of data quality that can arise when clinicians or clients make data entry errors, like misreporting a weight that a physician then relies on for a medication dosage, or understating or overstating symptoms. The use of cross checking software and other internal procedures to ensure data quality can really minimize those risks. A comprehensive look at EHRs is really beyond the scope of this training, but EHRs do often include integrated tools that are relevant to direct service delivery. So, for example, EHR systems, they can generate reminder phone calls and text messages. There are EHRs that let providers share access to a client's clinical record, and these are helpful when coordinating care. Sharing the clinical information among the providers and their supervisors can really enhance care and promote technology mediated supervision. And you can see more about this on the benefits of electronic health records resource that I provided here on this slide. In addition to addressing PHI related data security issues when providing computers and other internet enabled devices for client use, you need to decide whether to control the client access to websites that distribute pornography or provide downloading software that gives access to any illegal or unhealthy activities. These can be particularly thorny issues for your agency's TAC implementation team to kind of weigh out. Now let's talk about privacy and confidentiality considerations. There's been so much that's been written about HIPAA's privacy rules and 42 CFR Part 2 and behavioral health care. So this lesson's discussion of these matters is going to focus specifically on privacy issues that are related to TAC. Privacy is defined as the right of the client to control his or her own health data, whereas confidentiality relates to the duty of professionals who are granted access to that private information to protect its privacy. The issues of privacy and confidentiality are distinct from data security issues, which deal with administrative and technological protections that are meant to ensure that PHI is not disclosed to any unauthorized individuals. And privacy issues are equally important, and they have unique implications in technology delivered interventions. Earlier, we identified the risks that are associated with the device-based storage of text messages and the security concerns that were related to any unencrypted email exchanges. In addition, there's some mobile applications that use the internet or telephone to store and send client information back to the providers. So, for example, a mobile app might record the whereabouts of a client using a GPS system and provide warnings or support messages about their proximity to relapse triggers. Medication levels can also be monitored and the resulting information sent back to the clinician. These apps can really be helpful tools for the clients and the clinicians, but just as clinicians are responsible for documenting their rationale for recording sessions, clients have to sign a written informed consent document outlining the rationale, the risks, and the benefits, along with the protection, the storage, and the disposal of any identifying information that's retained by the provider. In addition to the usual elements of an informed consent to participate in services, a number of considerations emerge when delivering care through technology. And as with all informed consent, the consenting process has to ensure that the client fully understands the risks and the benefits that are associated with participation in that intervention. Technology introduces a new level of complexity and jargon that may be unfamiliar to some clients. So, TAC implementation teams need to be very diligent about ensuring that clients are fully informed of the risks and the benefits in a language that they can understand. This includes a full disclosure of the risks of losing that real-time control of their personal data through systems that maybe intrude into the client's homes or their personal environments for the purpose of monitoring their health and their wellness, in addition to the privacy and confidentiality risks. Advising clients of the risks and the benefits of participating in tax should really be an ongoing process. Clinicians have to be well versed in these risks to identify when risk potential changes. They need to be able to detect client ambivalence and also to initiate discussions of new risks or concerns. Informed consent processes should really address the limitations of the technology based intervention and the alternative interventions that are available. Although documentation of these discussions and agreements is really essential, ensuring that the client fully understands and agrees to these risks and benefits is going to be paramount for your organization. So consider how your agency is going to secure that written informed consent from the clients who primarily engage in services remotely. Clients can provide electronic signatures or select a box on a web page that acknowledges reading and understanding the information. But there are concerns in ensuring that the client fully understands and agrees to the risks and the benefits in this manner. Some programs use the low tech option of having the client sign and fax the form to the provider. Others require telephone or in person intake sessions that ensure that the client's actually fully informed. Informed consent should include information about the roles and the credential of each staff member who participates in the client's care. And this is going to include any direct service providers, support staff, and their supervisors. And I know it can really be difficult to verify identity remotely, especially when engaging with clients primarily over the internet or the telephone. So some programs require validation of identity, such as photo identification or a signature declaration of identity. Uh, Another way that programs address verification of identity and age is to require an initial in person or telephone interview prior to the inception of the remote care. In remote areas, video conferencing can provide an alternative to in person sessions. Biometric authentication devices like iris scan or voice print or thumbprint readers, these can provide cost effective alternatives for organizations. Agencies should also establish policies for verification of guardian consent. The process of obtaining that informed consent from clients should include their provision of any emergency contact information and their receipt of a disclosure of the procedures that the counselor or any other agency staff is going to use should the counselor determine that the client may endanger himself or herself or anyone else. Verify the client's emergency contact information at the time of intake just to ensure that your agency has that valid information about the client to use in the event of an emergency or for any mandatory abuse reporting. That informed consent process should also clearly indicate who the client should contact in the event of a crisis or emergency, and it should define the response time clients can expect. You may also wish to advise clients not to use email to communicate about any emergencies. Informed consents should also outline how and where the client's data are being transmitted and the risks and benefits associated with that transmission. This is going to include seeking explicit consent to transmit the image of a person, such as through video conferencing. Informed consent should address any risks of being overheard during audio transmissions and of any text based communications being intercepted by third parties. The informed consent process should also clarify how information is going to be transmitted and stored for clinical supervision. In addition to explaining risks, you need to give the clients information about what they can do to protect themselves from privacy breaches. Some advice may include not sharing their passwords or their email accounts with their family members, making sure they log off websites after each session, especially for clients who are living in group situations. Also, using virus protection software. Introducing clients to the internet or mobile technology creates potential for benefits and risks that extend beyond TAC itself. So providers have the obligation to help clients become informed consumers of technology in general. Responsible providers give their clients information on topics like viruses, malware, spyware risks, and protection, vetting internet resources, the risks of sharing personal information on social media, the risks associated with sharing software like music files, the importance of password and password management. Information available to clients should always be understandable, accessible, and for the very vulnerable populations, delivered in various ways. We should explain how fees for technology-based interventions are charged and how payments for TAC are made. This may require explaining insurance reimbursements and limitations of reimbursements, which type of interactions are billed, and the logistics of the payment. If clients wish to use credit cards, issues can arise regarding recurring payments, the name listed on the invoice, and where receipts might be sent. Depending on the type of technology used and the intervention's intensity, uh, advise the clients about how technology failures are going to be handled, including backup plans for clinical intervention and plans for handling technological problems. In any setting, a behavioral health service agency plays a role in ensuring that its counselors, its supervisors, and other clinical staff are providing services within their scope of practice and competence. This is often accomplished through formal credentialing and privileging procedures. Remote service delivery not only presents challenges in ensuring that providers are licensed to deliver a particular type of service in a specific jurisdiction, but it also demands that counselors develop new tax specific competencies. Organizational tax competencies, these differ from those required for agencies providing traditional in person services. So, for example, program implementers need to be sensitive to the issues as naming a moderated forum and ensuring that the scope and the role of the staff member responsible for moderating it is clear. Another example would be a client's potential inability to distinguish easily between a licensed professional's email and that of a support person who's responsible for logistical arrangements. You may wish to establish a policy requiring staff members to use full signatures that clarify who is sending the message, the role that the sender plays, and any alternative contact information for reaching the sender, like a phone number. It's important for behavioral health organizations providing TAC to adopt policies and practices that ensure coordination of care among the various staff members who are going to communicate with a given client. You might wish to consider providing clients with an acknowledgement that explains the limits of any technology-based service that's going to be provided and the terms of that participation, either as a part of the informed consent process or separately. You may also establish a process for identifying situations in which the use of technology could be counterproductive or dangerous, and enact policies for handling those situations, including when and how those services are going to be discontinued. In addition to requiring the collection and the verification of clients' emergency contact information at the time of intake, you should establish policies for handling emergencies when the client is not physically present at the service site. These policies may include adding warnings to notify the clients when there's an immediate response that cannot be expected, and how to reach a live person in the event of an emergency. Policies that define the timeliness of providers' responses to email and telephone calls, along with the clinical backup procedures during a provider's absence, is also going to be helpful. Both behavioral health service providers uh, should keep information on any local emergency services, and they should have some well established protocols regarding the responsibilities of partner providers and agencies. This is particularly true for any remote agencies where the providers are going to have the most direct contact with the clients, but may not have the expertise to address an emergency situation adequately. So, for example, it's going to be important to be knowledgeable of the civil commitment process and the available emergency mental and substance use disorder resources. And then, in addition to that knowledge, it's going to be essential to have clear agreements about the roles and the responsibilities so that local partners have a working relationship with your agency and its staff. Ongoing partnerships are going to allow for confidentiality and privacy concerns to be addressed in advance of an individual crisis situation. You might wish to institute procedures that document the circumstances in which providers can terminate treatment and ways that the provider should respond to both overt and any subtle requests from clients to terminate treatment. These procedures should include active referral of the client for continuing services with another reputable provider. Introducing TAC to rural or frontier areas has raised some concerns about the handling of emergencies that are required or that are unique to the delivery of TAC in these settings. So, the American Telemedicine Association recommends that behavioral health service providers working with rural populations discuss firearm ownership and safety with their clients. Maybe assess clients for substance use. Be familiar with the local emergency and behavioral health resources. They should also note the impact of emergency disclosures on confidentiality with regard to any overlapping relationships in small communities where nobody knows a stranger. And lastly, in this part of the lesson, I want to talk about regulatory considerations. As TAC rapidly expands, states and payers are scrambling to establish regulations to keep up. A survey of state mental health and substance use disorder agencies found that most states were using some form of telehealth, most often in mental health service delivery through web conferencing. At the time when they did this, only a handful of states reported using other technology for service delivery, and fewer than half had implemented any regulations. Of the 14 states with regulations, 5 required telehealth providers to meet the same standards that are required for in-person services. 3 required the providers to have formal protocols in place, and 2 of them required provider certification, and 2 modified their requirements from the standards for in-person services. A 2010 survey of state regulatory boards responsible for counselor certification found that 14 states had regulations for technology-assisted counseling, but only 6 of those states had regulations for technology-assisted supervision. 20 states had regulations either under discussion or in development. 7 themes were identified among the states with regulations, including a tendency to regulate technology-assisted counseling and supervision as a discrete specialty versus another mode of counseling or supervisory activity. States tended to limit TAC to special circumstances, like geographic isolation, and they required additional disclosures of the risks and benefits of TAC either by incorporating the information into any existing consent processes or by using additional consent forms. Most states required licensure in all states where TAC was delivered, but few of the states required any specialized training. Telemental health services use two-way audio and video transmissions that are addressed by the Joint Commission, reimbursable under Medicaid in many states, and reimbursable by Medicare in rural areas. Detailed practice guidelines for delivery of telemental health services and clinical supervision using video conferencing technologies have been established by the American Telemedicine Association. These guidelines cover clinical specifications like ethics, emergencies, and general practice issues, technical specifications, and administrative issues like policies that organizations should adopt. Most states are going to require that professionals engage in telemedicine practice with their professional scope and have a license to practice in the state where the client resides. Some states have state reciprocity regulations regarding licensure. Abiding by these state licensing regulations is often a condition of malpractice insurance coverage. Clients have to be fully informed of the potential risks and the benefits related to TAC and must also consent to the transmission of their data and images. Current TAC best practices include limiting practice to working with clients who live in the state in which the professional is licensed, providing tax services within the scope of practice authorized by the professional license, explicitly discussing with clients the risks and the benefits of TAC, participating in specialized training prior to engaging in the service delivery or supervision. The U.S. Food and Drug Administration, or the FDA, is developing regulations requiring certain tools and mobile applications to be approved as medical devices. The FDA deems certain devices to be low risk, and these can be used without FDA approval. Thank you for joining us at the Georgia Reentry Center. Again, my name is Desiree Cochran Norfolk. If you need to reach me, you can reach me on my email at desiree.cochran@gmail.com. Also, feel free to check out our other trainings and other resources that we have available on georgiareentrycenter.com and our online school. Feel free to take advantage of the other courses that we have and the referral program. Please continue forward with the next section in this training, and at the very end, you will take a quiz over all of the content in this course and all the sections, and upon successful passing of that, you will receive your certificate.